but there certainly are some people where that particular side effect doesn't go away, and then we may decide to try something else. Sometimes switching to a different stimulant or to a different formulation, even if it's the same active ingredient like methylphenidate, which Ritalin is one, but there certainly are multiple other formulations of that, including Concerta, where it's a capsule. On the outside of the capsule is a coating of methylphenidate. Then there's 3 different compartments inside the capsule. There's a absorption compartment where fluid from the gut is absorbed. There's a push compartment, and then there's the medication compartment, which is filled with the liquid form of methylphenidate, and as it goes through the gut, the liquid is absorbed from the gut, and then the liquid methylphenidate gets pushed out over time. And then there's a few others that are a capsule as well, where they have sprinkles inside. And I found, especially with some of my younger patients, that if we just switch formulation, we might actually get a little bit different of a response, including different side effects. So, we'll generally kind of talk, and based on what I'm hearing, we'll make a decision about what seems to be best.
What do you call a lower dose? 20 milligrams as opposed to 40 or 10?
A lot of times it's going to depend on the age and the size of the child that I'm seeing, where I'm going to start them at. And also, usually as I take my history, I kind of try to get a feel for how sensitive that person is to medication, because I certainly think there are some people who are generally more sensitive than others, and I may have a 17-year-old that I'm going to start on, say, the lowest dose. That's possible, just because they do tend to be somewhat sensitive to medications, and like I said, that's something that I kind of try to get a feel for as I'm taking my history. So, yeah.
With the decreased appetite has been kind of a big deal, and for a lot of people worry about. And I think when I was in training, I remember them saying that the studies have shown that if that has any effect on growth, that these kids tend to catch up later on in their growth. Is that still the case, or is there any more recent studies showing that that's not?
There have been some evidence in the literature that there can be, as a separate issue, decreased growth velocity, where the child may not grow as rapidly as you would necessarily anticipate. And usually when we do the drug holidays over, like taking the breaks on the weekend or over the summer or spring break or whatever, a lot of times we'll see catch-up growth. And some of the other recent studies have shown, especially with the people who are not able to take those kinds of breaks just because of the severity of their ADHD, that generally overall they don't typically lose very much height from what their predicted height would be, maybe only a few centimeters. And I certainly have some children that I see that have growth hormone deficiency, and I'll still put them on a stimulant, and the endocrinologists are fine with that. So, and with the suppression of appetite, we'll try different things. Some of it depends on the response that the person's had to the medication. If they're having a good response and it's really helping controlling their symptoms, we'll try different strategies. A lot of times I'll encourage people to try to have the child on more calorically dense foods, whole milk instead of skim or 2%, and adding carnation instant breakfast to add more calories. And a lot of kids like that taste of that better than they do like the Boost and Pediasure. I don't know if you guys have ever tried those, but they're not very good. So I'll have more success with the kids drinking the carnation instant breakfast added to the milk. So, and there certainly are some things that I know I do, and some of my colleagues who are child and adolescent psychiatrists will do to try to stimulate their appetite. If I have a child who's having difficulties with sleep, I may look at adding something like an antihistamine at night. There certainly are some pretty potent antihistamines that can stimulate appetite, and I've had some success with that. Or one of the other antidepressants. I have a few colleagues who use that one that can also have an appetite stimulating effect, especially, and it also tends to be fairly sedating. So it's one that they'll use, if the person's having sleep problems, and so that way we can kind of address a couple different things, and we're not just using it for, adding another drug to ameliorate side effects from the first drug. You certainly don't want to get into
too many medicines.
chasing your tail that way.
Right,
yeah.
right.
And polypharmacy, I think the majority of us try to avoid that if we can.
Could you talk a little bit about the therapy? When the conversation arises with a parent at school, a lot of times the first thing they think of is medication. You're asking me to put my child on medication. And that's not the intent at all. But not being in the field of psychiatry, it's hard to speak to that to a parent. What types of things do you do in a therapy session with a child?
Well, unfortunately, I don't get the opportunity to do much therapy. With what I do, I primarily do medication management. When I did get to do therapy, a lot of what I did was what we call cognitive behavioral therapy, where we try to link thoughts with the behavior that the child is doing to try to get them to stop and think. And there certainly are different manualized, very structured approaches that are out there and are available for therapists to use. I think the majority of therapists, a lot of times, again, it's going to be tailored to the problem that's originally identified with the child. So, if it is impulsivity, they'll probably use a stop-think approach with them or attempt that. And if we're seeing a lot of oppositionality, then they'll probably go and try to address that piece of things. Certainly kids with ADHD, with their tendency to be rather intrusive, do tend to have problems with social interaction. So, looking at doing some social skills kinds of things. And then I think that the medication, in my personal opinion, I don't know what other people would necessarily say, I think it's not necessarily great at specifically improving organization itself. I think that's one of those symptoms that gets secondarily improved as your focus and concentration and attention improves. Then you're able to organize yourself better, but sometimes they still need to be taught those skills and how to go about organizing. So sometimes, at least I know the therapists in my practice will work with the person on improving study skills and what are helping them think through and come up with some checklists on how to organize themselves better. Back in 1999, there was a large study done by the NIMH called the MTA study, and it looked at over 500 children. I think there were 6 different centers that were involved around the country, and they looked at multiple different settings. They looked at community practice. They looked at how the medical centers do their approaches to medication. And probably one of the things that did come out of that study is that the best outcome and unlike a lot of other studies where, if you look at research, a lot of times they're going to exclude any other sort of thing that may be going on. So they want to get as pure of a population as they can. So if you're studying ADHD, you don't want to have anybody in there that has any of those other comorbidities that I talked about. This study did not do that. So it kind of gave us a more real-life type of picture of what is going to be going on with a person who's dealing with ADHD.